Hi everyone, thanks for listening to my presentations. Today I'll be talking about dizziness and vertigo in children and adolescents. Okay, sit back and let's go. To save time, I will try to look out for reversible causes that could be handled immediately. And that will be checking out for the culprits, particularly medications, aminoglycosides, furosemide, minocycline, quinine or quinidine, and salicylate. Because if any of this is present and we correct this, we might be out of the problem. Dizziness is a disturbed sense of relationship to space. Now, true vertigo. Well, someone is asking me, why true vertigo? Does it mean you're going to have false vertigo? Yes, you're right. We can have true vertigo and we can have pseudo-vertigo. Don't waste your time. We'll get there in a bit. Vertigo is a disturbed sense of relationship to space with illusion of spinning. Okay? We'll see there's difference between that and dizziness. And the spinning is felt by the affected person in the environment, or the affected person is feeling that the environment is spinning around him or her. Vertigo could be an abnormality somewhere in the vestibule or the semicircular canal. And if it is occurring in the vestibule and semicircular canals, we take that as peripheral vertigo. It could be abnormality somewhere in the central nervous system, for example, the brainstem, cerebellum, vestibulospinal tract, and we tag that as central vertigo. The presentation could be dizziness without vertigo. That is also called pseudo-vertigo, and that will be with light-headedness or giddiness, and is caused by anemia, anxiety, ataxia, depression, hyperventilation, orthostatic hypotension, pregnancy, pre-syncope, or somatic symptom disorder. Still, part of the culprit when it comes to pseudo-vertigo will be arrhythmia, heat stroke, hypoglycemia, poisoning, or medication side effects. But if we're dealing with dizziness with vertigo, then we might be dealing with benign paroxysmal positional vertigo of childhood, or we're dealing with central nervous system infection, like meningitis. It might be head trauma, might be poisoning, medications, adverse effects, stroke, brain tumor, labyrinthitis, or vestibular neuritis, or we're dealing with complications of otitis media. Still on dizziness with vertigo, it might be as a result of cholesteatoma, which is a non-cancerous cyst or skin growth at the middle ear behind the eardrum. It is caused by middle ear infection or birth defect. It could be as a result of congenital defects, mastoiditis, Meniere's disease, middle ear effusion, middle ear trauma, seizures, Ramsay-Hunt syndrome, or perilimb fistula. Diagnosis of vertigo in children will involve taking history and physical examination, asking about sensation of spinning or moving, and checking out for history and physical examination of Nystagmus, any nausea, any vomiting, any past air trauma, any sitting down before now, any bone fracture, for example, temporal bone fracture, or any signs of increased intracranial pressure. Diagnosis will continue if there are no physical damages on CT scan, then we might be dealing with post-concussion syndrome. So at this end, we need to ask history of head trauma, particularly those children involved in sports, hockey for example, laboring concussion, post-traumatic migraine, and probably a sign of post-ictal state, that is, after seizures. So the history of seizure disorder is expected to be taken in this type of a child to be able to get down to the cause if we have taken the CT and it has come out to be normal. If there is no spinning, no nystagmus, no nausea, no vomiting, then we might be dealing with dizziness without vertigo, or we're dealing with syncope or ataxia in children. Okay, if there is prior head trauma history, but we have taken the CT scan today and there are no abnormalities or no damages on CT scan, then we need to find out any altered mental status. Is the altered mental status associated with fever? If the answer is yes, then we have to rule out meningitis or encephalitis. But if there's no fever, but the CT reveals abnormal imaging, we have to think of brain tumor or stroke. Okay, if no fever and no abnormal imaging, then we have to think of drug overdose. And at this time, we'll be asking the family for history of street drug usage, okay? And if this is an adolescent, then our suspicion should be very high as per street drug usage, like phencyclidine, ketamine, barbiturates, ethanol, and so on. But we might be dealing with migraine. If we have done everything, done toxicology screening, and it is certain no street drug usage, because there's no fever and no abnormal imaging on CT, right? If there's history of migraine here, we might be dealing with conventional migraine with dizziness. And this is a rare situation, but it's still found in children and teenagers. So it is characterized by dizziness, memory loss, anxiety, agitation, blurred vision, speech impairment, and so on. But one good thing is it is very rare. And that is why misdiagnosis is very common when it comes to confusional migraine. And we need to ask about history of convulsion or seizure disorder in this adolescent, because it might be post-ictal, particularly in younger kids, younger children. If no prior trauma and no altered mental state, then we need to check the ears. Otoscopy. If otoscopy reveals abnormalities, then we need to know exactly what abnormalities. Is this cerumen impaction? If that is the case, the journey is nice, it's fine, we can easily handle that. Are we dealing with foreign body? Okay. Is this epizystal urticus, that is Ramsay-Hunt syndrome? We need to be sure of what we found there. Okay. Middle ear effusion, e.g. serous or purulent labyrinthitis, could occur. In that case, we need to find out, is tympanic membrane distorted? Are we dealing with cholesteatoma? I've just explained what cholesteatoma is all about in just about 2 or 3 minutes ago. Perilymphatic fistula, post-traumatic perforation or ossicles disruption. So we need to be sure of what we're looking at. Okay, you could see that we are moving from one stage to the other. If the otoscopy is normal, that is no abnormality found during otoscopy, okay, then the question is is this associated with traveling? Because we need to know whether while traveling in a car, boat, or plane, and the answer is yes. Oh, I could remember, the first experience was when I was traveling with my mom, my uncle, my dad on a boat, or flying from one state to the other or country to the other and so on. That if the answer is yes, that is motion sickness. But if the answer is no, then we have to go one more step. We have to do vestibular testing. If we have positive head impulse and associated decreased hearing, we are likely dealing with Meniere's disease or drug side effects. But if we have positive head impulse, but no decreased hearing and no abnormal neuroimaging, it is likely we are dealing with benign paroxysmal positional vertigo. Are we having vestibular neuronitis or basilar artery migraine? If the answer is yes, then we are dealing with brain tumor or stroke. Still on vestibular testing, if no head impulse or the head impulse is equivocal after vestibular testing, then we need to check the neuroimaging. Oh, yeah, yes, there are some anomalies. Then think of stroke or brain tumor. But if the neuroimaging is showing no anomalies, or in other words, simply put, it's normal, then think this might be benign paroxysmal positional vertigo, or migraine, or seizures, or perilymphatic fistula. The test that could be done in any adolescent or a child presenting with dizziness or vertigo are listed here, but in the course of this presentation, I've gone through most of them already. So like head impulse test, Nystagmus test, dysarthric maneuver could be done, otoscopy, I've explained that, lumbar puncture after having your CT scan test done to rule out meningitis, particularly if there is history of fever. And laboratory investigation is not all that necessary or not all that compulsory, but if it is strongly suggestive, like you are thinking of hypoglycemia, you can have the glucose level down. And of course, if you're thinking about anemia, you can have complete blood count down. And we have to do complete and thorough physical examination and have vital signs done, taking temperature and the blood pressure and the respiratory rate, of course, and cardiovascular system fully examined, head and neck region fully examined, neuro fully examined, and of course the CT with temporal window. Magnetic resonance imaging will be fine if it could be done pretty fast. That is not a 1-year waiting list. Treatment. The treatment might be doing nothing. Just give pieces of advice depending on your findings. For example, if it is secondary to medication use, you just do something about that medication. Either you reduce the dosage or you use another medication entirely after discussing with the physician who prescribed it in the first place. Or if it is motion sickness, just counsel. Okay, it depends on the findings, but it might be multidisciplinary approach as well. Okay, treat any reversible cause or causes like meningitis, certain medications, like I've said, cerebral impaction, otitis media, and benign paroxysmal positional vertigo can be treated using canalitic repositioning, using airplane maneuver. And of course, Meniere's disease will be treated using such restriction and diuretics. You may choose to refer to pediatrician or ENT surgeon. And with that, I've come to the end of this presentation. Kindly remember to share and subscribe. Leave comment, I appreciate it.